Hello, my name is Dr. Lloyd Ratner, and I'm the Director of Kidney and Pancreas Transplantation here at Columbia University New-York-Presbyterian Hospital. The purpose of this video is to provide you information about pancreas transplantation. So the first question is who are candidates for pancreas transplantation? And the majority of people who wind up getting pancreas transplants are people who have type 1 diabetes and also have kidney failure. And the reason for that is that there are a number of benefits to pancreas transplantation, but there are also some risks involved. And one of the risks is the risk of needing to take anti-rejection immunosuppressive medications. People who are getting kidney transplants, who have kidney failure, will be on immunosuppressive medication for their kidney transplants, which is truly a life-saving operation. So they'll already be on the anti-rejection medication, and hence the risk of the pancreas transplant isn't as much as someone who had never had kidney failure or did not need anti-rejection medication for other purposes. The other people who can get pancreas transplants are those people who have type 1 diabetes that is very poorly controlled and difficult to control, what we would call brittle diabetics. So despite checking their blood sugars very frequently and being very compulsive about what they eat and when they eat and taking their insulin, their sugars are still not well controlled. Then there are people who have what we call hypoglycemic unawareness. So these are people with diabetes who, because of their long-standing diabetes, it's affected their nervous system, and they're unable to tell when their blood sugars are getting very low. And this could be a very dangerous situation because, as you are well aware, blood sugars go low, people could pass out, and if you don't have any symptoms that your blood sugars are getting low, you may not be able to tell if you're going to pass out. So the main categories of people who are candidates for pancreas transplants are those type 1 diabetics who have kidney failure and either already have had a kidney transplant or will need a kidney transplant, those patients with poorly controlled or brittle diabetes, and those with hypoglycemic unawareness. And those are the majority of patients who get pancreas transplants. There are a few other instances where patients can get pancreas transplant, and those include patients who, despite very good control of their blood sugars, the secondary complications like the vascular disease, the eye problems, the GI problems continue to progress. So those people are also potentially candidates for pancreas transplantation. And then also some people who are type 2 diabetics are candidates for pancreas transplantation as well. And just as a brief review, people who are type 1 diabetics basically don't make any insulin. And we check all candidates for pancreas transplantation to see whether or not they do make insulin on their own, or whether any insulin that they take is just injected. Type 2 diabetics make either a normal or even higher normal levels of insulin, but their bodies don't respond appropriately to the insulin and hence require much higher than normal levels of insulin to obtain good blood sugar control. Now, there are some people who start out as type 2 diabetics who, over years of having type 2 diabetes, their pancreas stops making insulin, and hence they convert from type 2 diabetics to type 1 diabetics. And these people are also candidates for pancreas transplantation. And then we have some people that are type 2 diabetics, their body makes insulin, but they're what we call phenotypic type 1 diabetics. So they look more like, and their history of their disease is more like that of a type 1 diabetic. So these people, as opposed to the majority of people with type 2 diabetes, the majority of people with type 2 diabetes generally develop it later in life, and it's associated with being overweight or obese. In people who have phenotypic type 1 diabetes but are really type 2 diabetics, they develop their diabetes fairly early in life, generally in their 20s or 30s, and are thin and otherwise look like type 1 diabetics and behave more like type 1 diabetics than type 2 diabetics. And then there are several subcategories that are associated with genetic defects, but that's really out of the scope of this discussion today. So those are the people who could be candidates for pancreas transplantation. So the big question is, what's the benefit of a pancreas transplant? And then the corollary question is, what are the downsides? So let's go over the benefits first. Number one, a pancreas transplant should enable the recipient to be off insulin, have good blood sugar control, and be able to eat a normal diet. And those things, most importantly, impact on a diabetic's lifestyle. And as people who have received pancreas transplants have told me, they said being a type 1 diabetic is always like waiting for the other shoe to fall. So you're always worried about how your sugars are, you're checking your sugars, you're worrying about what you eat, how much you exercise, how much insulin you take, and you're always worried and anticipating what the next problem is going to be. And so getting a pancreas transplant and having good blood sugar control and being able to eat whatever you want just takes an enormous burden off of them and makes much less work for them. And it's been studied that people to be able to get good blood sugar control often may take as much as 3 hours worth of work a day in terms of checking their sugars, being meticulous about what and when they eat, how much they exercise, and all that. So it's a big, big lifestyle advantage in terms of getting a pancreas transplant. The next advantage of getting a pancreas transplant for those people who get a kidney transplant is that it protects the new kidney from being injured from the diabetes. And obviously that's a big issue because most people who have kidney failure and are type 1 diabetics have the kidney failure because of their diabetes, and it would just be a matter of time before the new kidney would be injured by the diabetes. Number 3 advantage of a pancreas transplant is that it may slow down, stop, or even reverse some of the other secondary complications of diabetes, such as the eye disease, the vascular disease, the GI problems, the neuropathy. So it potentially could have an impact on those as well. So those are the big advantages of pancreas transplantation. Now, what's the downside? Well, the first issue is that it's a big operation, and it's much bigger than a kidney transplant. Generally, we do the pancreas operation through a midline incision in the abdomen, and there are risks associated with any type of major surgery. There are specific risks associated with a pancreas transplant. Now, the pancreas, besides making insulin and other hormones that affect blood sugar control, the pancreas also makes digestive enzymes which are used to digest food. And anything that either injures the pancreas or insults the pancreas, such as handling it not carefully, low blood pressure, rejection, any other things like that could potentially injure the pancreas can cause release of these pancreatic enzymes, which then cause inflammation both of the pancreas and surrounding tissue. And this could make the patient pretty sick. And so in order to get good results with a pancreas transplant, we're very, very particular about which donors we'll select for the pancreas transplant, how we take care of the pancreas, how we operate on it, and how long the pancreas has been out of a living human being also affects these issues. Now, the other problem with pancreas transplants are that As opposed to a kidney transplant, the pancreas has a different type of blood supply than a kidney transplant. And the blood supply to the pancreas is much more tenuous. So there's a greater chance of the pancreas clotting off and not being useful than a kidney transplant. The risk is small if we take a lot of the precautions that I mentioned before in terms of proper donor selection, proper handling of the pancreas, keeping what we call the cold ischemic time, or the amount of time that it's outside of a living human being, short. We reduce that risk to, very, very low, but it does require all those things. But the net effect is that when we weigh out the risks and benefits, for most patients who fall into the categories that we talked about earlier, pancreas transplantation will be beneficial for them. Now, there are two ways that you could get a pancreas transplant. The first way to get a pancreas transplant is to get a pancreas and a kidney transplant simultaneously from the same deceased or dead donor. Now, there are some advantages to this. The other way of getting a pancreas transplant is to get a kidney transplant first, usually from a live donor, and then get a pancreas transplant subsequently from a deceased donor. Now, the advantages of getting the kidney and the pancreas simultaneously is that it's very easy to monitor the kidney for rejection. Usually we could just follow the serum creatinine levels, and if those start to rise, we may need to do a biopsy of the kidney. And if there's rejection in the kidney, then if the kidney and the pancreas are both from the same donor, they will almost always reject simultaneously. Now, just as a review, rejection doesn't mean that the organ is going to be lost. It just means that your immune system is attacking the organ, and the vast majority of times we could successfully treat rejection episodes. So with a kidney transplant and the pancreas transplant from the same donor, it's very easy to monitor for rejection via the kidney. If the kidney's having rejection, the pancreas is more than likely having rejection, and we treat the rejection, we treat it for both organs. Now, if you get a kidney from a live donor or have a kidney transplant before receiving a pancreas transplant, and then get a pancreas from a different deceased donor than the kidney, then the likelihood of the two organs rejecting simultaneously is much less. So it's very easy to monitor the kidney for rejection, and it's more difficult to monitor the pancreas for rejection. There's not a good blood test that's as reliable for malfunction or dysfunction of the pancreas than there is for the kidney. So there's possible that we may miss rejection episodes in the pancreas transplant if it's from a different deceased donor than the kidney was obtained from. So why would anyone, if the results of the pancreas transplant are better getting them simultaneously from the same donor, why would we take the live donor transplant, or why would we get a kidney transplant first and then get the pancreas subsequently? Well, there are a couple of good reasons for that. Number one, the greatest advantage is derived from the kidney transplant in terms of life expectancy, quality of life, and the results of kidney transplant from a live donor are better than kidney transplants from a deceased donor. So if someone has an opportunity to get a good live donor kidney transplant, that's in their best interest, as opposed to having to wait for both a kidney and simultaneous pancreas transplant. So if someone has a live donor, I would say go with that donor, get the live donor kidney transplant, and we'll worry about the pancreas transplant afterwards. The other advantage is that in terms of the way that the organs are allocated, most of the time the allocation is driven by the kidneys, and people are going to have to wait a very long period of time to get a simultaneous kidney pancreas transplant. Now, if that's their only option, they don't have a live donor, that's one thing. But if they have a live donor, rather than have to wait for years to get the kidney transplant, they're better off getting the live donor and then getting the pancreas transplant afterwards. And in fact, the waiting times for a pancreas transplant alone, as opposed to the kidney and pancreas from the same donor, is shorter than if you have to wait for both the kidney and the pancreas from the same donor. So not only do you get the kidney transplant quicker, you'll also get the pancreas transplant quicker if you get the kidney transplant first and the pancreas transplant subsequently. Now, what about the issue of the rejection? Well, it turns out that only about 10 to 15% of people experience at least one rejection episode. So, between 85 and 90% of people who get pancreas transplants never have a rejection episode. So the vast majority of people do very, very well, even though we can't monitor the pancreas for rejection as closely as we would like to. Now, the operations themselves, for the kidney transplant, as you know, we make an incision in the lower part of the abdomen and we hook the kidney up to the blood vessels that supply blood to the leg, and we also hook it up to the bladder. If you're getting a live donor kidney transplant or a kidney transplant before getting a pancreas transplant, we'll do the operation that way. And generally we like to put the kidney on the left side so that the pancreas could be put on the right side subsequently. As I mentioned earlier, when we do the pancreas transplant, we make an incision in the middle of the abdomen, up and down in the abdomen, and we'll put the pancreas to the right side of the abdomen. If we're doing a simultaneous kidney and pancreas transplant, we'll put both organs on the right side of the abdomen, but we use that same midline incision. When we do a pancreas transplant following a kidney transplant or a pancreas transplant alone, the operation generally takes somewhere between 4 to 6 hours. And a lot of that operating time is spent preparing the pancreas. It takes quite a bit of work to prepare the pancreas. If we're doing the simultaneous kidney pancreas transplant, the operation may take as long as 6 to 8 hours, quite a bit of work. So there is also that advantage if you've already had a kidney transplant and are in better health by virtue of having the kidney transplant. When you get the pancreas transplant, the operation generally tends to go smoother, it's shorter, and things go very, very well. After the operation, whether it's the pancreas alone or a combined kidney pancreas transplant, most of our patients will go to an intensive care unit setting, either the surgical intensive care unit or a post-anesthesia care unit, or what we used to call the recovery room. And most people will spend 1 or 2 days in the ICU type setting, not because you'll be so sick, but just so we could monitor you very closely. Afterwards, the patients go up to the 7th floor in the Milstein building, which is our main hospital building, and that's our usual transplant floor. Most people could expect to be in the hospital for 7 to 10 days after the pancreas transplant. Now, the one other issue that you may have heard about with pancreas transplant is what to do with those digestive enzymes that the pancreas creates. In the old days, people, and there are still some centers that do this, we used to hook the pancreas up to the bladder and people would pee out those digestive enzymes. That is associated with a lot of complications in terms associated with dehydration, alterations in the body chemistries because you're peeing out all these secretions that the pancreas makes, and also local effects of these digestive enzymes. They could cause irritation to the bladder and urethra, which could be uncomfortable. What we do is that we hook the pancreas up to the bowel, which is where these secretions would go normally anyway. So that really reduces the complication rate of pancreas transplantation. Like I said, most people will spend 7 to 10 days in the hospital once they've had a pancreas transplant. When you're discharged home after the pancreas transplant, the follow-up and the anti-rejection medications will be just like that of getting a kidney transplant. So initially we'll follow you very closely, and as time goes on, we'll follow you much less frequently, and eventually you'll get to the point where we check your labs maybe once a month, and you come back for follow-up maybe 3 or 4 times a year. Obviously, you'll have the opportunity to ask questions of your surgeon, your nephrologist, an endocrinologist, and also our transplant coordinator and nurses. So please feel free to ask anything that you feel wasn't addressed in this video. Thank you.